in Switzerland. Raphael Heinzer in Switzerland was a former trainee of mine. We published this in the Lancet Respiratory Medicine in 2015 from Switzerland. I can tell you the obesity problem is much less in Switzerland than it is in the United States, although it's increasing. But they did polysomnography in the community to see what was happening. The patients who come to clinic obviously have a complaint. In the community, we went to see how many of them had sleep apnea. It was about 23% of women and about 50% of men met criteria for obstructive sleep apnea. You might say, why does it matter? Just leave them alone and let them stay there. If they come to clinical fruition, then we can take care of them. But otherwise, why does it matter? Well, in that context, the apnea-hypopnea index was predictive of hypertension, diabetes mellitus, and depression. I'm not saying it was necessarily causing all these diseases, but it was associated with these diseases. And it's hard to ignore these people when they're suffering from conditions that all of us take seriously. So we do believe there's a large global burden of disease with a clinical impact. So sleep apnea is highly prevalent. They won't all get cardiovascular benefit from CPAP, continuous positive airway pressure, because not all are at risk for sleep apnea-induced heart disease. So take-home message so far is that sleep apnea affects about 1 billion people worldwide. The numbers vary with the scoring criteria and the equipment used, but we need to think about how to address this global burden of disease. One of the treatments for sleep apnea is called CPAP, continuous positive airway pressure. It's not available everywhere in the world, but it is being used increasingly throughout the world. And some people don't tolerate it. So we published this paper in Chest to see how well tolerated it was. We have these big data analyses. There's an academic industry partnership called MedX Cloud, which I'm a member of. I don't take money from MedX Cloud or from the sponsoring companies, but we do publish a fair amount together based on the cloud. There are over 15 billion nights of data available on the cloud, more than 15 million connected devices. And so it's quite a rich source of data now. So the y-axis here is the cumulative percent of patients. And the x-axis here is time. This is drawn from almost 1 million patients with 137 million nights of data. Looking first at the blue guys here, about 70% of these patients meet the US Medicare criteria for adherence. They're using their CPAP regularly. If they're using modern technology with feedback and encouragement if they're doing well and helpful hints if they're doing poorly, it's about 87% of these patients are meeting Medicare criteria for adherence. And so the idea that nobody tolerates CPAP is simply not true. Usual care is shown here on the right. Active patient engagement is shown on the left. The green colors are very good adherence with CPAP, and the majority of patients use the CPAP quite consistently. Even with usual care, it's really quite good as far as adherence is concerned, and it's better than most other chronic medical therapies. We did propensity matching to match these groups. The bottom line is the idea that nobody tolerates CPAP is simply not true. We published this study as well in 2.6 million patients. About 75% of patients were meeting Center for Medicare Services, the US Medicare criteria for adherence, which is really quite good. It's better than inhaler use in asthma or anticonvulsant use in epilepsy or other diseases. We look globally as well. And so this is Luciano Drager. We published this a couple of years ago now from 4.1 million patients in the United States, 31,000 from Brazil, and 16,000 from Mexico. We don't have data yet from Bosnia. I looked in preparation for this talk, and we don't have that information. But 74% in the United States were using their equipment, 72% in Brazil, 66% in Mexico. Now, you might argue that these are all different health systems, and that's true. It tends to be the more affluent patients in Mexico who get treatment. But be that as it may, that was part of the point, was to look across different healthcare systems. We saw reasonably good adherence across all 3 countries. And these patient engagement tools, active patient engagement, were associated with benefits. They're grossly underutilized. But 80% of patients were still using the equipment at 1 year, suggesting, again, that positive pressure therapy can be given to patients even in under-resourced areas. The same is true in children. So Rakesh Bhattacharjee and I published this in the Lancet Digital Health a couple of years ago, looking at different age groups, different risk factors. And the bottom line here is even in 4 to 6-year-olds, 6 to 12-year-olds, 12 to 15-year-olds, 15 to 18-year-old CPAP adherence was more than 50% in all groups. and active patient engagement did better for all groups across different age groups. In 4 to 6-year-olds, it's probably parent engagement more than patient engagement, but it's still quite effective. So pediatric data support overall reasonable adherence and benefits to active patient engagement. Leak and residual sleep apnea in teenagers do the worst, but overall, people do quite well. Now, you might argue, why does it matter? And the answer is we don't know. We did publish this in Chest. I believe it's just published recently with colleagues from France. Jean-Louis Pepin is the first author, published in Chest. We did propensity matching, 365,000 patients. We matched these two groups, some that continued their CPAP and some that terminated their CPAP. And you can see a mortality difference here, survival probability on the y-axis, time on the x-axis. People that continued their CPAP did well. People that terminated did poorly. You might argue there's a healthy user effect. The people using their CPAP are different from people that don't use it. Maybe they have better diet and exercise. Maybe they have better health literacy. Maybe they have better socioeconomic status. And those things are all true. We've tried as best we can to account for those factors. We think this is not all explained by the healthy user effect, but be that as it may, it's an association. It's not a causal inference. So further work is clearly needed. We looked in chronic obstructive pulmonary disease, and this was just published in the American Journal of Respiratory and Critical Care Medicine recently, in the so-called overlap syndrome, sleep apnea plus COPD. And we do see a poor prognosis in those patients. We looked at U.S. claims data, comparing adherent and non-adherent patients. We did see improvements as far as emergency department visits and hospitalizations were concerned in association with therapy. Once again, it's not a causal inference. It was not a randomized trial. It was an association, but it was a parallel and significant reductions in healthcare costs, suggesting that treating these patients may well be beneficial. Okay, let me say a little bit about COVID and ARDS. This was obviously a big problem throughout the world, and so the United States was no exception, obviously. So Dan Sweeney is my colleague who's going to be speaking shortly, who was involved in this study published on baricitinib, which is a JAK inhibitor, and remdesivir in hospitalized patients with COVID-19. He did see a rate ratio of recovery of 1.16 and a mortality signal that looked quite good, although not quite statistically significant. The bottom line here is that baricitinib plus remdesivir was superior to remdesivir alone. So remdesivir is an antiviral. That was Dan Sweeney was also co-author on that paper from May of 2020, New England Journal of Medicine. And that was helpful in reducing recovery time, accelerating improvement in clinical status. That combination may well be beneficial. There are further data on baricitinib. Wes Eli was the first author on this, my friend and colleague at Nashville in Vanderbilt. In critically ill hospitalized patients with COVID-19 were receiving invasive mechanical ventilation or extracorporeal membrane oxygenation. Treatment with baricitinib compared to placebo is associated with reduced mortality, consistent with mortality reduction. So the take-home message here is that baricitinib, this JAK inhibitor, got emergency use authorization in November 2020. It's now being used in these patients. We're not seeing as much COVID ARDS anymore, but it is reassuring that these large-scale trials were done quickly and effectively, and it does give some reassurance that we're doing some good things in the intensive care unit. Eli Lilly, the company that has this, is now talking about a big sepsis indication beyond just COVID, but they're not there yet. We were also involved in the study on tocilizumab. Tocilizumab is an interleukin-6 receptor antagonist. I was the global principal investigator in this study, published in the New England Journal of Medicine. Connie Benson was a very helpful co-author or helper on this study. In this randomized trial with hospitalized patients with severe COVID-19, use of tocilizumab did not result in significantly better clinical status or lower mortality. But there were subsequent studies done later in the pandemic when steroids were being given concomitantly that suggested perhaps there were benefits in certain patients. And so Ivan Rosas, we published this in the eClinical Medicine. There was concern about this immunosuppression. Maybe it was leading to more infections. In fact, we saw fewer infections with tocilizumab. Time to negative PCR was also better with tocilizumab. And we're concerned we're attenuating the immune response. In fact, neutralizing antibodies were present in everybody at day 60, suggesting eventually there is an immune response to this, even with immunosuppression. And if you look at interleukin-6 antagonists in mortality in this meta-analysis, there is some signal there that there's a benefit overall. So in this prospective meta-analysis of clinical trials for COVID-19, administration of interleukin-6 antagonists compared with usual care was associated with lower 28-day mortality. This is just published in The Lancet, though, a few days ago, looking at the use of high-dose steroids. So we know that lower dose steroids in the recovery study look pretty good. Higher dose steroids, in fact, look worse. The mortality on the y-axis was higher with high dose steroids versus usual care. Usual care here included low dose steroids. And so important thing to know is that the use of steroids in these patients is not without risk, and the higher dose steroids did poorly. In patients hospitalized for COVID-19 with clinical hypoxia who required either no oxygen or simple oxygen alone, high-dose steroids significantly increased risk of death compared to usual care, which included low-dose steroids. The recovery trial continues to assess the effects of high-dose steroids. Patients hospitalized with COVID-19 who are non-invasively ventilated, invasively ventilated, or on ECMO. But giving high-dose steroids to patients who aren't very sick may be problematic. I'd like to now talk a little bit about gas exchange and mechanical ventilation. This is an area of research for me, but I'll try and make it, again, generally accessible. This is something we published in the Journal of Applied Physiology last year. Peter Wagner is one of the pioneers of gas exchange research. Kim Prisk is my colleague here as well, who recently retired, but very, very knowledgeable about gas exchange. If you look at the arterial alveolar CO2 difference on the y-axis and the alveolar arterial PO2 difference on the x-axis, there's some patients who have primarily dead space, that is ventilation without perfusion. There's some patients who have primarily shunt, that is perfusion without ventilation. There's some that are in between. Why does that matter? Well, if you look at patients with COVID-19, they fall into different categories. So this is something we published in the European Respiratory Journal relatively recently. There's some of these COVID-19 patients have primarily shunt, that is perfusion without ventilation. Some have primarily dead space, that is ventilation without perfusion. The reason that matters is we're concerned about microvascular clot in some of these patients. The patients that have ventilation without perfusion are probably the ones that have perhaps microvascular clot. And so we're trying different therapies based on the underlying physiology, thinking that might be better than just giving everybody anticoagulants, which hasn't particularly worked in clinical trials. So alveolar filling, which can cause shunt, or pulmonary vascular obstruction, which can cause dead space, may be independent and variable, and this is perhaps a therapeutic target. The other point to make, though, this is currently in peer review. This is the same group that we've been working with, looking at patients during recovery. So the solid boxes here are people who are sicker with COVID. None of them were that sick. Very few were critically ill. These are hospitalized patients. And the open circles are less sick. If you look on the x-axis here, time, here's shunt, and here's dead space. And more than 10% alveolar dead space is quite abnormal. You can see quite a few patients here, even a year after COVID infection, have elevated dead space. The reason that matters is we know there's this issue of long COVID, and we're finding objective abnormalities in many of these patients, even who had very mild illness to begin with. So recovery from COVID-19 was associated with increased shunt fraction in 37% of patients, and dead space of EDVT in 86% of patients, persisting for about 13 months post-infection. These are cross-sectional data, but you don't really get the sense that things are improving over time, cross-sectionally at least. The people a year later don't look any better off than the people a month later. So the NIH severity, which is the severity of illness, predicted shunt, but not dead space. Again, these are people with mild illness a year after a COVID infection. Some of them just had coughs or colds, weren't even hospitalized. And a year later, they're still quite abnormal. So increased dead space suggests pulmonary vascular pathology persists post-COVID-19 in most patients. The reason that's important, this may not be unique to COVID. This may be true of other viral illnesses and viral infections. We're studying it now. But the fact that we're identifying objective abnormalities in these patients who were previously being labeled as crazy or something's wrong with them, we don't know what, we're finding objective abnormalities now, which might be helpful therapeutically. So in terms of gas exchange in COVID, there's microvascular clot may increase dead space, that is ventilation without perfusion. There may be a role for selective anticoagulation. There's this issue of self-inflicted lung injury, which probably does not occur from high ventilatory drive and mechanical injury. We have some data on that, which I didn't show you. And impaired hypoxic pulmonary vasoconstriction, that is the area where the body can cut off blood flow to areas that are poorly ventilated, might be present at least in some patients. These persistent gas exchange abnormalities are demonstrable even after mild illness. This may not be unique to COVID. I'll say a little bit about mechanical ventilation as well. This is an area of interest for me. There's this issue of driving pressure, which is the plateau pressure minus the PEEP on the mechanical ventilator. That seems to predict mortality in New England Journal meta-analyses. The trials were designed with a fixed tidal volume for the most part, but the amount of report has been corroborated. There are some issues with using this dead space, which I think is important for a general audience. On volume cycle ventilation, you have a peak pressure, a plateau pressure, and a PEEP down here. The driving pressure is this difference shown here. You can think of it as the tidal volume divided by the compliance. But the point is there's lots of different things that can go on here in terms of driving pressure. We're often taught to try and minimize the driving pressure. What I'll say is there's lots of different ways of reducing driving pressure. You can either increase the PEEP or reduce the plateau pressure. The problem is because of the heterogeneity of the lung, that may be good or bad, or there may be different ways of doing this. Increasing the PEEP in somebody that's got recruitable lung may make it look more homogeneous. Increasing the PEEP here may actually overdistend some portions of the lung. If you have decreases in tidal volume, that may lead to some atelectasis in some cases, or in other cases, it may be beneficial. So using the driving pressure in isolation may be problematic, and just look at the whole patient, not just that one number. The other point I'd like to make is about prone positioning. Prone positioning is something that's readily available throughout the world, doesn't require a lot of technology or a lot of expense. And if you put people in the prone position, there's a mortality benefit, as Claude Guerin showed in New England Journal. Survival on the y-axis, time on the x-axis. The prone patients had better survival, quite markedly so, compared to the supine patients. We wrote a fair amount about why aren't we using it more and what's stopping us from using it more. And the answer is still not clear. We started doing it a lot more during the pandemic, and now recent data have suggested we're no longer doing it as much as we were during the pandemic. It's not entirely clear why, but it is a simple and cheap and accessible treatment that everybody can use throughout the world. It may be helpful for prevention of lung injury. It may be helpful for therapy as well. The mechanisms whereby it works are beyond our calling today, beyond our scope today. But prone works by reducing gravitational distribution of lung stresses and reduces lung injury. And it tends to work best in patients who are getting protective mechanical ventilation. So we know the ventilator can be life-saving, it can also be life-threatening if not set appropriately. And so minimizing the stress on the lung and increasing the PEEP on the lung. If you do that in the context of prone position, that's where the biggest favoring of prone positioning was in patients who are getting low tidal volume, protective mechanical ventilation. And then there's some barriers to implementation, which we've looked at. So Shannon Cotton is a nurse that I work with who's working on her PhD. And there was a survey done where 96% of doctors, but only 39% of ICU nurses thought the prone position would be helpful for their patients. So we've written a fair amount about challenges and solutions and the importance of teamwork. But I think this disconnect between the doctors and nurses requires teamwork and communication, as Dr. Begovic was talking about in the introduction. And as I mentioned, there may be a role to prone positioning even before respiratory failure. So Cameron McGuire and Alex Pierce work with me and have been looking at prone positioning to reduce the need for intubation patients with COVID-19. There was a meta-trial published in the Lancet Respiratory Medicine. It was shown up here, and we can get into the details of that later. But if you look at proning in non-intubated patients, there may be a signal in terms of reducing need for intubation. Less clear in terms of mortality benefit, but suffice it to say prone positioning is something we can do throughout the world. So take-home messages about prone positioning. We know that proning works. but is underutilized, particularly with lung protective ventilation. Likely works through mechanical protection of the lung. Prone uses increase in the pandemic, becoming less common again now. Likely works in non-intubated patients as well. But these barriers to implementation, including communication, need to be addressed. This paper just came out in New England Journal a few days ago about giving steroids for community-acquired pneumonia. And the bottom line here is among patients with severe community-acquired pneumonia being treated in the ICU, those who received hydrocortisone 200 milligrams per day had a lower risk of death by day 28 than those who did not. And so important for a general audience to know that there is a benefit to giving steroids in community-acquired pneumonia in a large study. Here's hydrocortisone versus placebo. Percent of patients discharged from the ICU, you can see an improvement with steroids. And I'll close with a little bit about COPD, chronic obstructive pulmonary disease. And the GOLD executive summary was just published in the American Journal of Respiratory and Critical Care Medicine a few weeks ago. This is the Global Initiative on Chronic Obstructive Lung Disease. The reason it's important is they have a new definition for COPD. GOLD defines COPD as a heterogeneous lung condition characterized by chronic respiratory symptoms like dyspnea, cough, expectoration, and/or exacerbations due to abnormalities of airways and alveoli that can cause persistent, often progressive airflow obstruction. That's the new definition of COPD. They remove smoking from the definition in recognition of the fact that air pollution and cook stoves and indoor and outdoor air pollution may be problematic. In some studies, more than 50% of COPD may be non-smoking related. I think this is important for developing countries and for under-resourced areas. We think of smoking as the main cause of COPD. It's no longer in the definition. There are a couple things to point out in terms of therapy. We can talk about LABAs, these long-acting beta agonists, and LAMAs, long-acting antimuscarinic agents. So there's indacaterol glycopyrronium versus salmeterol fluticasone in COPD. You can see an advantage to the LAMA-LABA combination versus the inhaled steroid. Indacaterol glycopyrronium was more effective than salmeterol fluticasone in preventing exacerbations in patients with a history of exacerbations during the previous year. And then triple therapy, that is an inhaled antimuscarinic, long-acting beta agonist, and inhaled steroid, different doses here, looks pretty good, triple therapy compared to less therapy. Triple therapy with twice daily budesonide, glycopyrrolate, and formoterol resulted in lower rates of moderate or severe COPD exacerbations than glycopyrrolate formoterol, that's LAMA-LABA, or budesonide formoterol, that's a LABA inhaled steroid. So this triple therapy with all three does look to be better. And if you look at the data here, is cumulative incidence of moderate to severe exacerbations, it looks better with the triple therapy. And here's death from any cause, also looks somewhat better with triple therapy. So I'll summarize the whole talk. Thank you all for your attention. In summary, I can say that sleep apnea is common and therapy is helpful. Having a defeatist attitude about it is no longer justified because CPAP is used by many patients throughout the world. COVID-19 ARDS led to rapid progress in pharmacology and reinforcement of basic principles of critical care. Often people will say in developing areas that we don't have access to this expensive drug or this expensive therapy, but sometimes just basic principles of critical care and communication and prone positioning, things that are readily available, can make a big difference for patients. Steroids may be helpful for pneumonia, as I showed you in that very recent New England Journal paper. And COPD is no longer just defined by smoking, and therapy is certainly helpful based on randomized trials. I'd like to thank you all for your attention. Be happy to answer any questions if there's time. Thank you.